Great. Well, welcome to Kike's talk on group visits and primary care. I'll pass it on to you, Kike.
Thanks, Paulius. Hi, everyone. Such a huge honor to be here talking about my passion, which is group visits. A little bit about myself. I am a physician scientist for the most part and an entrepreneur. My background is infectious disease epidemiology and population health. I've worked with several public health entities like the CDC Foundation, the state of Texas, the city of Houston, and multiple other public health entities. I've helped with syndromic surveillance of bioterrorism-related conditions, and also I've worked extensively on COVID. However, during the course of my career in public health, population health, epidemiology, I fell severely ill with a chronic condition called Hashimoto's thyroiditis, which many of you know about. And so I wasn't a textbook case. I turned out to have several other things that were unexplainable by my doctors. I was particularly diagnosed with idiopathic angioedema with urticaria. And so I would turn up with hives every day without knowing what the trigger was, went through several tests, wasn't given a specific diagnosis or treatment to really allay my symptoms or make me feel better. And also for my thyroid, I was told the only solution was to do a surgery to take out my thyroid. I literally had a goiter also. What I, had at the back of my mind was, why am I experiencing this? Is there anybody else out there who has specifically my own challenges as well? What were the triggers of my symptoms? Because I just realized that every day was different, right? I would wake up and go in front of the mirror, try to identify, like I would look at myself and I would look different from what I looked like the previous day. It was just, nothing was predictable. So I started going online looking for answers, like most patients would. And I found a group on Facebook called the Hypothyroid Mom. This group consists of over 1.2 million people, and it's still growing up till today. What I found in that group was that a whole lot of people were sharing their lived experiences, and I realized that there were quite a lot of people in that population that had my own experiences as well. But a few things that I learned from that group helped me have better informed conversations with my doctors to say, hey, have you checked on this? How about that? For example, vitamin D. During my course of treatment, nobody told me that potentially vitamin D was related to my autoimmunity or could be making it worse. And so they tested me and found out that my vitamin D level were almost deathly low. And so I started getting, large doses of vitamin D. And then, I realized that I was under a lot of stress, and so at the end of the day, I didn't have my thyroid taken out because I had information that I learned from other people with lived experiences like mine. So that experience made me think back, like, how is it possible that something I learned from a social group was able to help me improving my health? I realized a whole lot of talk around nutrition triggers, lack of sleep, and then certain things in the environment that could potentially make me feel worse as a thyroid disease patient. So the question at the back of my mind was, why are doctors not in the forefront of the social context of what patients were experiencing outside the clinical encounter? Also was the fact that there was so many misinformation and disinformation on these social media groups. A lot of people were prescribing snake oil type things to help the thyroid heal, which as a physician, I knew that, some of these things were just not science-based. And so at the end of the day, to cut the long story short, 4 years in a row now, I have been given a complete clear that my thyroid is fine. I do not have autoimmune antibodies against my thyroid anymore. So I look at this story of mine and imagined how many people had to get the surgery or procedures for other conditions that could have been avoided if only the doctor had enough time to address the social determinants of health factors that might be affecting that condition, or even looking deeper to see what other things could contextually be affecting this patient that the patient is not aware of, or the doctor doesn't even know to test for. And so one way or the other, I don't remember exactly where the bell rang in my head. I thought to myself, how about doctors begin to have groups of patients, in appointments? I did a little bit more research and found out that there was something called shared medical appointments. But then what is the incentive for a doctor to want to be in a group with a bunch of people when they don't even have enough time for one-on-ones? Then I found out that group visits were actually reimbursable by insurance. And that was where the idea of creating a platform for shared medical appointments started. And so with that, I began to do a lot of research. I began to learn more on how to implement it. But from my understanding, it's quite difficult to implement shared visits because of the different moving parts. How do you schedule 10 to 15 people for one appointment, or even 5 or 6 people for one appointment? The other thing is, how do you manage things related to privacy and confidentiality, HIPAA, right? How do you manage those things? The other part was, what do you do before the appointment, during the appointment, and after the appointment? Who manages the group? How do you manage group governance, right? Those are questions that I had to figure out in the course of building out shared medical appointment programs. Then another question at the back of my mind was, who is doing this? What have they done? How did they do it? Come to find out that large health systems have actually been doing shared visits for so many years, especially for conditions relating to behavioral health, like cardiovascular diseases, weight loss, mental health, of course, prenatal care. And they've achieved a whole lot of success. But the problem was many of these visits were done in person that was constrained by time, space, and medical personnel resources. And so with that, I began to realize that during COVID, which was exactly when this idea came to me, people began to look at more innovative ways to still do group visits, because during COVID, like all things in-person groups and gatherings went away. So I decided to create a software called Wellness Suite to help facilitate group visits. Now, historically, since the time where hospitals started looking at how to do shared visits virtually, what I have found was many people tried to do it on Zoom, like we are right now. But the problem with Zoom is that there is no way to capture conversations. Like I can see there's chat going on in the chat box right now. But after this call, maybe Poilus, who is the organizer of this event, will have access to the text, but the rest of us might not be able to go back and retrieve what was discussed. And so some of those pain points are the things that we need to identify and solve for as we begin to build group visits. And so with that, I'm going to share my screen and show you a few things about group visits that I have learned over the past few years. Can everybody see my screen? Perfect. Okay, I'm going to try and move this bar away from the top of my screen. Give me 1 second. Okay, we're good now. All right. So thinking about shared medical appointments or group visits or group medical appointments, there's just interchangeable words you can use to describe the same thing. The reason why people typically do shared visits is to solve for specific problems. The first being the workforce shortages we're experiencing right now in healthcare, not just in the United States, but across the world. But also the fact that there is high cost and utilization of healthcare resources. There is a growing aging population, but not enough doctors to fill the gaps and the needs of these aging populations. And of course, as we know, the more people grow older, the more chronic conditions they're susceptible to, right? The other thing is lack of structured data in existing EHR, especially for population health and public health management. The other part is physician burnout and heavy workloads, which ties back to the fact that there is more demand for healthcare, but less supply of healthcare providers. The other thing is concerns of health equity and care gaps, right? Which is something that insurance payers are always looking for to solve for, or accountable care organizations, right? And like I mentioned earlier, a growing population of chronic complex diseases with chronic complex diseases. So group medical appointments, I like to personally call them medical group hugs. However, to put it in better context, they're pretty much health experiences where the wisdom of the patient meets the expertise of a doctor. So I feel like when patients are able to share with their doctors what their lived experiences are, doctors are better informed, and they're also better in position to offer good care that allows the patients like and trust their doctors. One of the problems I identified in that social group I was part of was many people did not like their doctors. Complaints around, my doctor did not spend enough time with me. My doctor did not test me for this. They keep increasing my doses. I don't feel better. They didn't even answer many of my questions. And so those problems are really the pain points patients have, right? So a group medical appointment essentially has three components: the care team, the patients being educated, and the care plan, which is targeted interventions. And I'll explain how group visits come together in such a way that it's efficient and also cost effective for not just the doctors, but for insurance payers and the patients. At the end of the day, it should be a win-win-win for all the parties involved. So the pain points that group visits address, which I mentioned earlier, was just the fact that patients want more time with their doctors, but more importantly is they need to have a reliable source rather than having social media where they're sharing their health information and also getting a lot of misinformation from a community of people who are not licensed providers, right? Now, there are three types of shared medical appointments. The first being the program group medical appointments, the drop-in group medical appointments, and collaborative group medical appointments. I'm going to describe each of these in the next few slides. So group medical appointments might be provided by physicians and non-physician providers as well, like physician assistants, clinical nurse practitioners, and certified nurse midwives, depending on the type of group that is being conducted. Then also places where group visits are actually quite common are in FQHCs and rural health clinics, where doctors who or specialists who are in high demand in those areas live like 3 hours away from the community. And so in order to be able to fill the need of all the people who need appointments with them when they do come to the small rural area, they tend to put their patients in groups and also tend to manage these patients as cohorts with specific conditions rather than having clinic with multiple different conditions showing up. Now, talking about drop-in group medical appointments, this term DIGMA was actually coined by someone called Ed Nofsinger. He is considered the father of group visits, and he described drop-in group medical appointments as, say, a doctor who has, maybe a primary care physician now, has 30 diabetic patients, but he has a panel of 200 patients that he sees. Maybe he's 30, amongst his 30, 15 tend to show up every week. And so he decides and say, on Tuesday, 6 p.m., I'm going to be hosting, well, that's if it's virtual. Let's say Tuesday, 10 a.m., I'm going to be hosting group visits for all my diabetic patients. So if you need a medication refill, you have questions to ask, or you have a new symptom, you want to get tested, show up in this appointment and we will address your concerns. So that's what drop-in group medical appointments are. Nothing fancy, it's just pre-scheduled. The advantages of this is that, let's say a patient is newly diagnosed and is still trying to understand the context of their chronic disease, we can allow them show up in a drop-in group medical appointment so they can continue follow-up care. Now, it doesn't preclude the fact that if the patient wants a one-on-one with the doctor, they definitely can get it. The other good thing about drop-in group medical appointments is they can be good for post-surgical care. Most times, surgeons are touch and go, whereby they do their procedure and the patient may never see the surgeon again, but they're referred to a clinic where they get to see a specialist or a primary care physician. Now, what happens is sometimes the patient has specific questions or post-surgical concerns that the primary care physician may not be able to address. And so sometimes it's wise to have like a group for specific surgeries. For example, people who go through bariatric surgeries, right? They still have concerns that the surgeon is the one who is able to address. And so rather than just discharging them out to the clinic, it's sometimes beneficial to have a group whereby maybe once a month the patients can show up and just come and share their concerns. The other type of group medical visit, which is my favorite, is the programmed group medical appointment, which is considered, also called P-GMA, right? These type of group medical appointments are great for people who have chronic complex diseases that will always exist. People who have diabetes, hypertension, chronic kidney disease, or autoimmunity that require consistent self-management. They're going to be on multiple medications. And so because of the amount of information that these people require for them to be able to manage their health, program group medical appointments are quite efficient for those. So the way this works is you set a time, maybe 6 weeks, 12 weeks, or maybe 6 months, where these patients meet once every 2 weeks, once a month, or once every 2 months, depending on the amount of care needed. And you specifically put together content and assessment, or even sometimes lab testing that you want these people to follow over a specified period of time. What happens is these people begin to understand their condition better. They begin to trust and also appreciate that their doctor is incorporating health education, lifestyle management, or even nutrition in their care. They also build community support around their condition because they begin to identify each other within the group. And then the also good thing about this is it removes the burden of setting appointments for these patients. So it kind of gives some form of expectation to the patient and of course the care team as well of what is going to happen for this person's care. And lastly, the collaborative group medical appointments. Now, Co-GMA is a different type of medical appointment whereby rather than the one-to-many or maybe two-to-many, whereby it's the doctor and a nurse or a coach with, say, a group of 10 people. In this case, Co-GMA involves, say, 3-4 different doctors or specialists managing a specific patient with a chronic complex condition. A good example is a patient who has chronic kidney disease, who is also an hypertensive, who also has diabetes and has other, issues surrounding their condition. Now, because these patients tend to use up a lot of medical resources, health systems and some, group practices try to adopt this collaborative group medical appointment to help reduce the amount of time the patient spends in a hospital or the frequency of ending up in the ER. You can also consider it a multidisciplinary care delivery model where different specialists come together in one appointment and addresses the patient and all their concerns. It kind of helps in care coordination, and also it helps the doctors collaborate and increase their knowledge on this patient and build a good care plan that allows the patient follow through in a systematic way. Now, the key features of all of these group visits is the fact that they are physician-led collaborative teams, whether it's the Co-GMA, DIGMA, or P-GMA. And forgive me if I'm using too many terms. If that's too confusing, someone drop me a chat and then I'll always spell it out. I'm a bit conscious of that because I've used those terms so many times. The other thing is patients are seen in groups of 15 to 20. Now, the reason why we put them in teams of 15 to 20, cohorts of 15 to 20, is the fact that even though you have a group of 15 to 20, not all of them all show up in every appointment. So you try to be able to, use resources more effectively and also to save cost. You want to have 15 to 20 patients, and maybe in an appointment, you get 8 to 12 most times. And depending on how much time is being spent, you can easily manage 15 to 20 in a group. Now, patient education, nutrition support, and lifestyle coaching is always beneficial in a group setting, because as many of you might already know, the social determinant of health factors contribute more to a patient's health outcome than the actual treatment you as a doctor give them. So it's wise to always address these issues. Patients love them. They always appreciate when their doctors tend to talk about these issues surrounding their social drivers. The other thing is creating a collective goal and care plan for the group, meaning even though you want to personalize care for everyone in the group, there are certain things that are just standard of care for every diagnosis that you most likely going to furnish to each patient. However, if you can create groups in such a way that you're using a population health lens to look at the group, it would help you begin to measure outcomes in a way that allows you to set goals. And then as you're tracking the group, maybe you have, and this is best especially for P-GMAs, by the way, because it's time limited. It has a specific goal that you're trying to achieve. Maybe if you have a group, okay, let me give you an example. One of my clients, who is a gastroenterologist, she noticed that a lot of her patients who have GERD, reflux disease, right? Many of them should not be on the medications they're on. Maybe some of them have been on these drugs for 5 to 10 years. And of course, using PPIs come with a lot of side effects or risk, especially when it comes to bone resorption. And then some of them may now have rebound effects, so that they have to continue to increase their doses of PPIs. So she decided to set a goal that some of these patients, she's going to put them through a PPI wean-off program over a 6-week period. She's going to teach them how to eliminate certain foods, how to sleep better, or lifestyle changes they can make to actually help reduce the amount of dependence they have on PPIs. At the end of that cohort, what we found out was most of these folks could actually control their reflux disease using food and lifestyle changes. And some of them actually needed surgery. So we're able to achieve that goal. We measured the number of patients who ended up in surgery, those who ended up reducing their doses of PPIs, and of course, those who completely weaned off their PPI. So the point is, set goals collectively for the group, but then individualize the care. Now, one of the things I like to highlight is the experience for the physicians and also the patients, not just the physicians, really the care team, right? One thing we've discovered was that group visits actually help reduce burnout, because you feel like you've taken care a huge part of care delivery for some patients, not all your patients, some patients in a group setting where you've maximized time when it relates to questions the patients ask frequently and often, and then also spending less time not doing too much work on documentation, because now you're documenting as a group. That gives you more time to do what you love doing, being in front of the patient, rather than documenting and doing EHR work. And then also streamlining the care, whereby what you're doing is quite predictable and programmed. And the last thing is it just increases satisfaction and work-life balance. That's what we found with many doctors who have been in group visits. For the patients, patients love peer-to-peer support. Like myself, who found that group of 1 million people, I just thought it was, ridiculous that over 1 million people would be on Facebook talking about a medical condition. And this group was not started by a doctor, not by someone who is medically trained. And everybody just trusted the community to share their personal health information, right? Several people showing surgical scars saying, I think this thing is infected, it hurts, it's red, and my doctor says nothing is wrong. And then like people begin to pile over this information and start throwing out comments on, oh, it's bad, go get a second opinion, right? And so in my mind, I'm like, patients love having people validate them. I loved that people validated what I was experiencing that my doctor said wasn't true or wasn't needed to investigate further. And so the point I'm making is the experience for patients is quite positive, because they just love to find other people like them to validate their experience. The other thing is data security and confidentiality. I've always worried about what if I make a comment on Facebook about my health and somebody punches my personal profile picture, sees about my life, my children, and I am very quiet on social media, but I just worry, like, what is my health information doing on social platforms, right? The other thing is the fact that it's fast and easy to access care through group visits. If you've programmed a group visit for a specific time, the patient has the decision whether to show up or not to show up. And there is no issue of no-shows really in group visits. It's a matter of how many people came in the group, right? And it depends on also how you decide to bill, which we will talk about later. Then the other thing is the fact that patients feel like they spent a lot of time with their doctors. Group visits typically run between 60 to 90 minutes, depending on how you decide to structure it. If you decide to do breakout rooms or you just want to do a common room where it's just everybody in the group. So patients love group visits for these different reasons. So how do group visits really work? So think about it. The current state of normal traditional healthcare delivery is you do like maybe 3 visits in 1 hour. And I decided to be generous with the time, saying 20 minutes, but you know that maybe 10 of those minutes are spent in front of the patient, and conservatively another 10 is spent documenting, or maybe the patient's vitals are being taken by a medical assistant or whatnot. But roughly, we can assume that you spend 60 minutes on 3 patients, right? So that means in a 6-hour day, let's say overall 6 hours, you're seeing 18 patients, which typically we know is not the case. I've met doctors who have 30 patients in a work day, right? And at the back of my mind, I'm like, how are you really getting the time to address questions or some other things that your patients would need within that short period of time? But we know there isn't really enough time because we have to get patients through this door as quickly as possible, right? Anyway, so the target state is group therapeutics. I call it group therapeutics, which is a term that I coined because I'm looking at this from a digital health perspective. And so just like you have digital therapeutics, a digital health platform for shared visits is considered a group therapeutic platform. And so with that, if you do 15 people in 1 hour, in a 1 hour group visit, essentially, that means you can see 90 patients in 6 hours. Now, typically, this is not in the real world, you don't find yourself doing 6 groups in a day. That's typically going to wear a doctor out. But this is just to show what the time value looks like if you were spending 6 hours doing groups, right? So the ROI in time and cost savings is up to 5 times potentially. Now, what are the benefits of having group visits, right? Number one, overall, you find out that the quality of life for patients improve because you're not just giving them medical care, you're addressing other social factors like nutrition, stress, lifestyle, and whatnot. The other thing is it improves effectiveness clinically for the care team because you see that there is more engagement from the patients, and also the patients tend to adhere more to care plans. So it makes the burden lighter for the providers. Compliant patients are most likely educated patients, right? And so at the end of the day, what I love the most about group visits is the fact that it reduces the administrative burden on the care plan, simply because we've taken care of a portion of documentation just by having groups. And then when you do the individual care plans and personalization, you can just add a tweak to what you've done for the group. Now, how do you find patients who are eligible for insurance coverage? I'm just going to go over this very quickly. Patients who are eligible are usually patients who already have an established relationship with the practice. This is not good for first-time patients, and the reason being that group visits have to be condition specific. So if you've not diagnosed this patient or you've not been referred, this patient has not been referred to you, this patient should not be in a group visit with you. The other thing is, like I said, it should be condition not specific. It should be voluntary, and there needs to be enough time to cover the needs of the group. Now, these guidelines are very specific from insurance payers, and so I literally had to put this in a checklist to make sure that every group visit has this before we can say, yes, this group is ready for insurance billing. Now, if you were to be billing cash pay or you're doing direct to primary care, that is a different ballgame entirely. But I just thought this is information that is necessary to know. Now, how you recruit patients into your group visits is totally up to you. You can recruit from your clinic directly. You can do online marketing. A whole lot of doctors who do group visits I have seen do online marketing. They're typically doctors who are inclined to lifestyle medicine or integrative medicine and coaching. Other part is if you're contracted with specific employer groups, you can also recruit from there, and also from strategic partners if you're doing more of innovation around your care delivery. So this is the first step implementation process from start to finish. What happens is a patient comes into the clinic, gets a one-on-one appointment, gets a diagnosis, and then is either referred to a doctor who does group visits, or within the clinic, there is a group and the patient is referred to the group. And then the patient enrolls either through email, website, or mobile app. And from there, they're assigned a specific group, whether based on their condition, their location, or social factors like maybe age, race, or sex. Like, for example, women's health group for pregnancy, right? And then the fourth step is personalized care after they've, been integrated in the group. Every other thing here is pretty much more on the digital health side. So I'm not going to go over this, but if anyone wants the checklist, I have it in a nice document. Group participants always need to have a checklist to understand what to expect before, during, and after the session. And so I always like to keep things simple and well documented step by step for the patient, so you don't have too many people falling off the group because they just don't know what to do. Now, this is what a group visit looks like. I try to put it as much as possible visually, but I hope it's clear enough. So how group visits happen, like I try to put the sweet spot here, which is 12 people and a team of 3. Now, the reason why I say team of 3 is to give it a balance between whether it's a programmed group or a collaborative group, right? And say, imagine it's just 60 minutes and you want to host breakout rooms. Now, this essentially is what you would do on a digital health platform, right? For in-person groups, this is completely different. It just depends on how the clinic is structured. And so I can't speak much to that because it's just too nuanced when you talk about different clinic settings, right? But for online telemedicine, what you have is, say, 12 people in a group, and then there is a doctor, there's a physician assistant, and a health coach or group moderator. So there's a common room like we all are right now, and there's the coach talking to folks in the group. And while that is happening, there is a specific topic they're talking around patient education, and then the doctor does a breakout room for about 5 to 7 minutes. And the reason why we chose 5 minutes is because historically it's been known that most times the doctor spent about 5 minutes talking to the patient, and the patient gets about 3 minutes talking to the doctor. So we crunch it to about 5 minutes so we can have effective time, 60 minutes, where everybody in the group can get time with the doctor. And at the end of the day, they feel like they've spent a lot of time already with the doctor because they got a whole 60 minutes, not just with the doctor, but the health coach and other people in the group. And so billing for group visits, essentially billing is exactly as you would for regular E&M codes like 99212 to 99215. I'm pretty sure most of us know how these are billed, but the rationale for billing insurance. So according to CMS, and I think it was the American Association of Primary Care or Family Medicine, I'm not sure which one, they actually went doing some research, and CMS responded saying that under existing CPT codes, a physician can furnish a medically necessary face-to-face E&M visit or telehealth, since when there were telehealth accommodations made because of COVID. regardless of if the patient are being observed by others. And so from a payment perspective, nothing stops you from billing just like you would normal E&M as long as proper documentation is done. Now, challenges and considerations, right? Legal and regulatory considerations. So how you manage this is to always have everybody sign a waiver before the group visit, before they even join and enroll, saying, hey, I understand that I'm going to be observed by other patients while my doctor sees me, and I agree to that. The other thing is confidentiality. I will not share anything that is discussed in the group. And if anyone tends to share anything within the group outside, I absolve my doctor and the care team from the liability. So you spell everything out exactly as you want it in that waiver. And most patients typically, they're fine signing that. I mean, if they will go on Facebook sharing all their health information, I found out that people don't mind really joining group visits just because they feel like they trust their doctors and their care team. And so at the end of the day, most of these challenges can easily be solved as long as you have the right team, the right technology, and you have willing patients. Same thing on data privacy. This is just extra talk around it, but it's the same concept, making sure you dot all your I's and cross your T's. So how do you get started, right? The first thing is to identify the need in your practice. Who are the patients who need this? Stratify them by risk. Which ones have the risk of ending up in the ER or ending up becoming complicated, like your diabetic and hypertension patients? You want to make sure you keep them in a group visit where they can learn, nutrition, lifestyle, so they don't end up as a chronic kidney disease patient. And then you begin to craft targeted interventions. What would you like to put in the group visit? Do you want to create a care plan that includes behavioral health, mental health support? Do you want to include a meal plan, a fitness plan, and whatever? Like, do you even want to have like regular testing, maybe every 3 months for the cohort? You decide what interventions you want, and then you put it and build it into the group, and then you do a closed loop monitoring, consistently getting feedback from the patient and the care team to make sure that the program is running well. Metrics to evaluate program impact. This is super dependent on you and also on the conditions you're trying to treat through group visits, and then also what type of practice you're running. Is it DPC? Is it an ACO? Is it insurance-based? All of that is super flexible, dependent on what you currently do. So I love scorecards in the sense that it helps me really see holistically how well a program is doing. So this is a sample of one of the scorecards we did for a group, and I'm happy to share a template with anyone who is interested. We measure patient recruitment. How many people did we recruit? How many did we enroll? How many stayed through? Outcomes, physician productivity, reimbursement, and whatnot. But like I said, I can always share this with everyone. So current opportunities and demand in the industry for shared visit. These are all the hospital systems currently that I'm aware that are doing group visits. Happy to share this with you. You can go on their website, learn a whole lot on how they're running their group visits. But as you can see, most people are doing it on Zoom or Teams or hybrid, right? So that's it. I think we have about 12 minutes for questions. So do you want to take questions now, Paulius?
Yeah, this has been super amazing. I love it. Really organized presentation, Kike. Thanks. So the chat has been very active. I
Okay.
will call on a few people, I think. So there was definitely interest around payment. And when you, Robert, you asked about different payers. Do you want to share your question out loud?
Yeah, Kike, appreciate you taking the time to chat with us today around group visits. Certainly interesting. I'm curious, when you were listing out those rules, was that consistent across kind of the major commercial payers? Is this across both kind of Medicare and Medicaid? I guess where did that kind of rule subset typically apply to?
That's very good, a good question. Mostly commercial. And the one that I use the most for what's it called? As an example is Blue Cross Blue Shield, right? They actually have a policy, which I'm trying to pull up, Blue Cross Blue Shield. I'm going to show you right now. Blue Shield group visits right here. Okay. And they had very specific terms, which was across board from all the research that I made, right? Everything's listed here, and this PDF I can drop in the chat for everyone to go read, but exactly what I had listed is what they had. And the same thing, Medicare, medical as well. I did research on, and I don't know if anyone is from California, but medical has those same conditions as well. And so as long as you can check off this list, you will be able to bill insurance for group visits. Does that answer your question?
And yeah, and Kike, I think you might have been pulling it up on a second screen, not the one that we can see.
Oh, okay. I
yeah.
just dropped it in the chat if you can check it out.
Yeah, that sounds good.
Okay.
We'll share it in our Slack as well. Then, Dr. Afridi, you had a lot of great questions and points. One of them was around targeting different subsets of patients. So I know you're particularly interested in HIV patient care. Do you want to add more context to that question?
Yeah, thanks. So Kike, thank you so much for a very informative talk. In my mind, I was thinking about this probably 10 years ago when I was taking care of my transgender patients, and I wanted to discuss with them all of the different things that we talk about in a normal visit, but a lot of times there's a lot of stigma. Some of those patients are coming from 2 states over. A lot of them don't have the means to take the bus there, and so this would have been great at that time because then I could go over all of the different things and we could split it up into different transition groups as well to talk about what is it, how do I treat trans patients, and then how what are some of the concerns, and then I would love to bundle this with like an STD informative group as well, because there's a ton of opportunity in that space because nobody's going out to visit those folks, and those folks also are stigmatized, the most stigmatized patients, and so they're not really welcomed into offices, especially here in the South. I'm here in Georgia, and so I find that would have been great. And so in my mind, I thought it was a great way to close the gap with a lot of those stigmatized groups. Certainly, I think it'd be helpful for other groups as well, but I think about the people who can't make it in most of the times, but they always have a ton of questions.
Absolutely, absolutely. The way we have addressed that, so when we started using a platform. I don't know if anybody knows Practice Better, but you would know who is passing comments. People were not anonymous in the forums. Of course, if you're on Zoom like this and you're doing a group visit, you can turn off your camera and change your name to whatever, and nobody would know what you're doing. But one of the problems I saw was the fact that there was no way to be anonymous. And so we built a platform specifically that allows people to be incognito. And so you show up as an avatar and you can share away whatever you want to share. And so in my opinion, I think you have to look for innovative ways to help your patients feel comfortable being in groups, but you will be surprised. I haven't checked, but if you check on social platforms, you see that people there's groups for HIV, but it's going to be a closed group, but there's got to be a way you can do it such a way that makes the patients feel safe. But at the end of the day, I think it's the amount of support that they get from each other, and then trusting you is what's going to make the difference really in how they participate in the group.
This is really cool to hear that you've done that.
Can I add on to that question? So the other question I had was, if you do end up seeing, like you talked about the sweet spot being 12 patients, if I'm seeing like more than that, am I then going to take, after I'm doing that 60 to 90-minute visit, am I then going to take 2 hours to document for those 20 patients? Or does your software, make it easier? Like, I guess I'm just thinking in myself, like, I would kill myself having to do 20 of the same progress note like over and over again. And something about that wouldn't feel right to me. And so those are some of the thoughts that go through my head.
Yeah. So there are some things in the notes that are common to everybody in the group, but there are so many other things that are not common to them. Half of the work is done because you're doing it in a group, but then the other half is you have to find out when you were in the breakout room with the patient, what did the patient say? What was the chief complaint? Did you have to order a lab for this patient? Did you do a medication refill? That's not going to apply to everyone in the group, but at least you can talk about what was discussed, what the goal was, what the care plan was for the entire group. And so I would say for documenting, our software allows you to do documenting for the group. So the initial part is taken care of, but you'll have to add the rest in your EHR. Now, the thing is, we've not finished the process of creating integrations into EHR. When that happens, then it's going to be much easier. But for now, I would say, yes, do half of it as a group, but the other half you have to do one by one.
And then I think you also had a question about which time of the day group visits tend to happen the
Oh,
most.
yeah. Yeah.
Around this time. That's what I found.
Okay.
Many people like to do group visits, and the reason is because family members are around. We typically encourage family members to join sometimes because it just increases the, what's the word? I'm looking for a
Buy-in?
word. Yeah, it can,
The buy-in?
yeah, exactly. Buy-in. The patients feel like they belong. You just hear family members saying, I've always wondered why he acted this way. I didn't realize, because then they heard somebody else in the group talk about the experience. And so it kind of helps improve the outcomes and the patient's willingness to adhere because they feel like my family is now involved in my care. And the good thing is, if my family, like all my siblings, I have 4 siblings, they all live in the UK, right? If I had a group visit I was going to, because they've always heard Kike was sick, she might be going through surgery. If I had invited one of them to be in a group visit, like this is what's going on with me, it would have made a world of difference. They wouldn't have had to travel across the world to come be with me. So the point I'm making is this time of the day is best for most people to meet because mainly because their family members can join their group visits, essentially.
Yeah, that's fascinating. To improve our innovation outcomes, we will have to invite family members of everybody here as well. Okay. Then I had a question about in your slide. I don't know if anyone else was wondering, but you had 2 clinicians and in a 12-person group, each one saw 6 patients. So is one clinician billing 6 patients or are they able to bill 12 each?
No, they're billing 6.
They're
They're
billing.
6. Now, for the health education that is incident to the actual visit, you bill 12. So we're imagining this is for a specific practice. Now, if it is a collaborative group medical appointment, you cannot bill all 12. It has to be whoever saw the patient bills for the patient.
I'm trying to find what other questions I did not surface yet. I feel like y'all will speak up if you have something on your mind. The only other, so feel free to either chat or cut me off. But I feel like what's interesting is, Matt, you're at Sutter, and Sutter is listed as one of the places that are using shared medical appointments. Do you have any comments about that? If you
Yeah.
can.
No, yeah, appreciate it. I'll be honest, I'm finishing notes while listening. This is super, super helpful, though. Thank you for sharing all of these things.
Classic
Individual
primary
notes, no
care.
group notes, unfortunately. Yes, I think we have actually the patients with diabetes group visits, and we weren't able to launch it, but we were actually doing Medicare wellness visits as group visits because again, so much of the questions and you're just like kind of checking the box for a lot of it, and a lot of the teaching on patient education stuff, it can be delivered in a group setting. So those are the 2 use cases off the top of my head that I remember us trying out.
Mm-hmm.
Thank you. That's really helpful. And then we didn't get to talk about this, but maybe we can take it to Slack about this concept of 1-to-1 versus 1-to-many versus many-to-many and many-to-one. But I think that's kind of an interesting framework to explore. you know, just for the sake of time, if I can ask everyone to turn on their cameras who are away, if they can do that. If not, that's okay. But I love taking a photo for the group for our yearbooks. Awesome. Perfect. Thank you for humoring me. I will stop the recording, but we can hang out and chat if people still have time.
Yeah, I'm kind of responding to chat messages.